Well, first of all, thanks so much for this complimentary surgery. It was, as you know, I was pretty happy with my two transplants already. That being said, I had, one area, few areas maybe like in the crown that was not touched previously.
First of all, good morning, and you're very welcome. Once again, thank you for coming to us for your third surgery now this time. And well, this third surgery was basically details, working on details. We were touching up on little things. Of course, the crown we didn't ever touch. We decided to do it this time as per your request. And then we did notice there were some areas which were a bit fainter, a bit less coverage that needed to be improved. As for the rest, well, we did some improvements to your temple points, which you also expressed some concern about. And especially on your left side where you would like to part your hair, you would like to have a bit more coverage and density in that area. So we also gave a special attention to that area. And then, well, the rest was just sprinkling around a few grafts to
a chair on top
of density. Exactly.
That's great. So, and how do you find my case in general as a whole? Was it like difficult, easy, anything special about it?
Well, it's not one of the easiest cases, right? Norwood 5A is already quite advanced. And well, in terms of your surgery, well, the surgery has not been the easiest surgeries. Especially the first, because, well, everything is a surprise in the first surgery. You never know how exactly the patient is going to respond. So first surgery was the hardest day we had of surgery ever.
I remember.
And on the second day, of course, we already took some precautions in order to avoid stuff like bleeding and popping, which you did have quite a bit, especially on the first day. As the second surgery came, it was easier, but of course, it's always a challenge. It's always something that I have to be counting on. I have to be very adamant about certain particular things about the surgery in order to avoid or to minimize those things. And well, your case in general, you do have fine hair or finer hair, and your donor area, however, is quite good. Is quite rich. The hairs are very, very spread out. So in the follicular units, they're not very close by. They're not very bundled together. They're a bit spread out. So sometimes it requires us to use a slightly larger punch, but we never went over 0.85 in your case. So it's 0.8, 0.85. And well, donor area was well studied, as you know, and your total calculated as using our coverage value as total donor capacity is in the 13,000 grafts of safe, meaning that's quite high. We don't want to be close to that, but theoretically, you would still have coverage if we were to reach that kind of graft count.
Why would I need ever have transplanted 13,000 grafts?
There's
nowhere to place this.
You won't. No. Exactly. That's why we do medical treatment as well. Yeah. And I would say, even looking at the calculations, my guess is that would be a bit over. I would stick it to the 11,000, 12,000 maximum.
And well, actually, speaking of the calculation, so I brought, just as an idea, slightly lowering the hairline, just during our initial conversations, and I wasn't sure about it. I asked your opinion. I thought, why not? Maybe let's see what Dr. Ferreira thinks about it. And you obviously said you weren't a fan. Let's say.
Yes.
Could you elaborate on that?
Easy. Well, first of all, we already in the first surgery went very, very close to your native hairline. So as you do that exercise that we do, which is raise your eyebrows and to look at the insertion of the frontalis muscle, we have a good idea of the insertion of the original hairline, the adult hairline in this case, not the adolescent hairline. And we are pretty much there. That was one of the reasons why we designed your hairline in such a way. So it has that curve, that recession, which I think is very fitting for you. And we never want to go below that. We never want to go too much below where hair starts to be on top of the wrinkles that form on your forehead. So that's moving. That starts to look unnatural. And the other reason is, well, the cost is much higher than to simply add density. You're building a whole new area that has zero hair into an area with hair. So considering the density you have in the rest, where you have already done 3 surgeries, this time was the 3rd surgery, we'll probably will have to come back and increase the density there to make it match what you have behind.
Never ending story.
Yeah.
And obviously, I just wanted to ask how many grafts you think I have left. We partly kind of discussed this already, 11,000. So, about this.
Not
you
left,
really still
minus what we already did.
Of course, yeah. But I still believe I can extract 3,000-4,000.
Yes, so we can. It's your donor area. There's one thing about your donor area, about the way your skin heals, is that it does white mark. It has a lot of white dotting. The technical term is more like hypertrophic scars. And they were actually a bit raised. And that's why I tried to give the idea of the keloid scar, which is something much more extravagant. Just to make understand that your scars have a tendency to raise. And the way they reflect light make them look a lot worse than they really are. But we've seen that they've flattened it a bit over time, so that helps. But still, the contrast in your skin does make it very conspicuous, the difference. But you still have a lot of hair in your donor area. Okay, if you look at from a tangent, you will see, and just focus on the hairs, not the skin, not on the difference in color of the skin. You'll see quite an even surface of hair in quite a large amount of it.
So what's your perspective on mega sessions? As you know, some doctors are just going all in. Some of them are quite, conservative. I noticed doing roughly 3,000 grafts, 3,000 something grafts per surgery. What's your view on doing a bigger ones, and what's your philosophy?
This is quite a funny question, interesting, because in the last World FU Institute meeting, I was the scientific director, and I did a whole session on giga sessions and mega sessions. We did a whole debate on that. And I invited some doctors who are quite famous for going for large numbers, like Dr. Filip Pitela from Brazil and Dr. Sepslim Zdarev from Bulgaria. So in order to build a discussion, I also did their presentations about what they do, those very large sessions, very large surgeries. And I did a presentation about, what could go wrong with those and what are the downsides of those, just to, keep the discussion and, to also for the audience so for the doctors who are interested in going to those, to understand what could go wrong and what not to do, and why maybe it's only for a select few cases to do something like that. So that's one of the first things that these are for select few cases. But there are a lot of downsides to going for a large number of grafts. So, one of the things is, if you're doing a large amount of grafts in one time, imagine something goes wrong with your surgery. Then you already used up a large amount of the donor. Yeah, and if there is a survival issue for 2,000 or 3,000 grafts is much different than a survival issue for 7,000 grafts, right? Another thing was, it's much harder to predict. It's much harder to homogenize both the donor area and the recipient area, as you are not having more chances to look at it and to go incrementally, increase the density incrementally. There's also the other way around. You can actually waste grafts. You can waste grafts by using too much. There are many things that can go wrong there, and I could do a whole presentation on that. So I'm trying to keep it short. I'm trying to keep it short, but I think the most important part is, if you want to maximize survival and you don't want to risk damaging the donor area, so causing damage to adjacent flicker units, then you would like to go for smaller sessions. But here we can go, usually it's in the between 3,000 and 4,000 mark. We sometimes go higher if it's a patient that's right on the edge of needing a second surgery, or if you can just do a little more effort, expand slightly the donor area, or be slightly more aggressive, so as to avoid the patient for coming to our second surgery. And that's what we will do.
Interesting one. So I'm not only myself, plenty of people notice online that doctors in this region, like Spain, Portugal, pretty much all of them are using implanted pens.
Yeah.
Why is that?
Well, my take on it is the influence. I'm not 100% sure about the history of this, but a lot of the doctors or clinics who had doctors in the beginning, like the early 2000s, I think they trained with the DHI in Athens. So I think they were one of the first to start to use the implanters in surgery. So that's why they call it DHI. And basically that technique is what came to the Iberian Peninsula. And the first doctors who started using those are just a great influence in the doctors around. Like, for example, Dr. Jose Lorenzo, of course.
Obviously.
Well, 2003, that's when he started. He started using implanters. So, even when I started, I was looking at Dr. Lorenzo's videos, and I'm pretty sure I'm not the only one. So, technique just happened. And well, by coincidence, it's, in my opinion, the best technique.
Although there's a heated debates online whether, standard VE permit incisions is better than DHI. I mean, I've seen plenty of, as a patient advocate, I've seen plenty of, examples with the standard, slit and place, technique. Amazing results.
Oh, so you can get great results with everything.
It's probably, as always, it's important, the hand that's, using the tool.
But we've done, there have been studies in comparisons that we find that, in the right hands, like if you're really good at your technique, you probably will have a great result. But comparing just the techniques in general, implanters offer more protection for the graft. Mm-hmm. They offer more precise placement and more depth control.
Beard grafts or any other body hair. Mm-hmm. I've noticed you, well, at least in my case, you haven't even suggested any such thing. Well, for starters, I don't have beard. But obviously, when would you consider using beard grafts? I know you're a fan of just using donor, to begin with.
So we actually use beard hair. We've been using beard hair in many patients over the years. I do prefer scalp hair, and I'm more a fan of scalp hair if the donor allows us to. So in your case, that's what happens. Like your donor allows us to have enough scalp hair not to need the beard. Beard hair has a different hair growth cycle. It's still quite large, enough for us to like using it. Much unlike body hair, which has a very short hair cycle and much finer hair, doesn't really offer too much coverage. It's something that is the last of the last resorts. Okay, so but beard, yes, we use, and I like to use it more in between existing hair, never closer to the edges, never closer to the hairline, just in between
the mid-scalp kind of
crown area, mid-scalp, maybe behind the forelock, where we can mix it. But beard hair is always something that can look slightly more conspicuous if you're not smart about where to place it. It's in general, they are thicker and they're more single hairs most of the time.
And they can be like wiry or growing in kind of...
Also, yeah, that can happen. So in terms of blending in, and there's another thing, which a lot of, and you'll notice this in a lot of men, is that their beard turns white much quicker than their hair. So sometimes you would have a thick white hair sticking out in the middle of, so that's just another thing to be aware of. In general, just mix them with the scalp hair, and don't use it exclusively, for example, in the hairline or anything like that.
I bet that would look awful. Well, since it's my third transplant already, and each time we shave my head.
Yep.
Why is that?
Well, you just need to look at it. See, even when we were doing the prep for the surgery, you're like, oh yeah, because when I shave, you will see much better where the gaps are. That's exactly one of the things that happens when we shave. We have a much better overview of everything. We have a much more detailed view of where exactly the gaps are, and we can see the distance in between each follicular unit. Also, imagine not shaving in doing the extraction pattern you have now, where we went here, when we cherry-picked most of the grafts. We went to some areas more along the edge to have finer hairs. It's way harder to do something like that without shaving. Way harder. And we were implanting front, crown,
all around
temporal points. We were all around. So we need a very holistic view of everything. Of course, after the surgery, then also hygiene is much harder when you shave and when you don't shave. So my personal preference is to shave. So so as not to compromise the result, shaving is always better. In some cases, well, we may accept the compromise if the patient really needs, for some reason, not to shave, but only for small cases, never for...
So you've done in the past?
Yes, yes, many cases. But if you were here and you said, I just want to touch up something here on my hairline, and it's just like 50 grafts, oh yeah, we're not going to shave for 50 grafts. But like you, it doesn't make sense not
Although
to shave.
I was thinking, people were asking me, so are you going to shave your head again? I was like, yeah, why not? I don't care.
Well,
Funny
you
enough.
if I recall correctly, you actually shaved it on your own volition without having surgery, right?
Yeah. To me, it's simple. It's just easier because after the hair transplant, obviously you have to be super careful when you're washing your hair, donor, and everything. It's just why bother? Because with longer hair, it's obviously, like you mentioned, hygiene. You have to be everything top notch. So why compromising? Who are some of your favorites, like kind of colleagues, doctors who you think are doing great work?
Well, I have quite a few. I would say, well, I'm very biased. Most of these people, because they're also my friends. But I could speak, of course, of Dr. Jose Lorenzo, who was something who I worked alongside a few years ago. There's Dr. Verduni from Belgium. I think he's doing great work. Dr. Lucien Rahal, who's one who we don't see mentioned as much, but he does excellent work as well. To mention 3 people, even my also friend who shares the same name of Dr. Bruno Pinto also does good work. And I wouldn't want to skip a list. Dr. David Josephitis, USA. So it's hard for me to keep it short, and I don't want to skip any names.
Yeah, look, it's so not...
I can give you a few.
That's fine.
But of course, also...
Make notes.
not to forget, that even we mentioned him before, Dr. Zarev also does excellent work.
So during the surgery, we've been briefly discussing oral minoxidil. I'm obviously taking oral minoxidil, 2.5 milligrams. Been already probably 3 years, I'm doing fine. And you kind of been asking me multiple times, not just during this surgery, but even in the past, whether I would like to increase the dosage to 5 milligram, because that's what we can. And it kind of intrigued me because I just want to know basically your view and opinion on oral minoxidil, because something, it's not a new drug, but it's relatively a new kind of phenomenon that everyone started using all of a sudden.
It's definitely new in popularity, yes. Even for me, I remember at a certain point we never used it, and when I think this was 2019, I remember when going to ICHRS meeting, and there were some doctors there who were saying, oh, you can use minoxidil, you don't even need to use finasteride. I'm like, I don't think I know about that, but at least sparked me an interest in the oral minoxidil, and it has grown in popularity as I've seen more people using it. Okay, I thought, all right, I'm convinced. Let's start trying it in my own patients. And now I use it quite a bit. And we've seen good results with it. My opinion is that it's a valuable drug. It's a valuable addition to the arsenal. I use it frequently. I do not think at all that it replaces finasteride or dutasteride. Completely different principles. But it's a good thing to add some more density and some more girth to the hair.
What's about the dosages? Like what kind of dosages you prescribe, or you think it's worth exploring?
I start on the high end actually. I usually start if patient is someone like yourself, healthy male patient, healthy weight, everything in normal. I will start 2.5, and then I'll increase the dose actually very quickly. In 2 months, I might go for 5 milligrams if everything's going well. No kind of side effects, and it's actually quite rare to have side effects, or at least that I've seen. My patients, they don't seem to complain much about side effects.
And is it because you're going straight to the kind of more studied efficacious dose, or why exactly 5 milligram? Why not 2.5? Why not even less?
Well, I adjust, for example, for women, I don't start at 2.5, I'll start a lower dosage. If someone of very tiny stature, I might go lower. But remember, this drug was initially developed for hypertension, right? Yeah. Now we don't use it much for that. And the dose was 10 milligrams. We are using 25% of that. So it's very, very short dose, very low. Safety is quite studied. So I would not worry about starting a higher dose than sometimes people see using 0.5, 0.8, 1.0. Yeah, well, you can take a precaution in the beginning. Yes, I was a bit more precautious with the patients I started lower doses. But as you gain experience, you start to gain confidence and you start to understand exactly where you can go with the dosage.
And while we're on medication, what are your thoughts on topical finasteride or even dutasteride?
Not a fan.
Why not?
Not a fan. So various reasons. And the first one I think is not as effective. And I know there are studies that say it's as effective, but I haven't seen it. And also, going back to what I said in the initial mega session questions, we also did a session on that. I also did a debate on that. Yes, a few colleagues went around and we asked what their opinion is on topical versus oral. And everyone said they don't see the same efficacy. And then there are other reasons. Even if it would share the same efficacy, you would probably have an adherence problem where if you have to use a topical, it's much harder for people to do it long run and to keep using it. Okay?
Consistency.
And then there's a consistency, as you just said, is another thing, because how can you be precise about the dose every single time and apply it always in the same place? If you have longer hair, it's much harder to apply a topical. So there are a lot of things that go against using topicals. I have nothing specifically against it. So if a patient has a somewhat stable alopecia, and I would say, well, it would be nice for you to use to take finasteride or finasteride, even if it's a lower dose. I prefer not to take pills, but only for patients who are stable. Okay, but I'm happy to use topical. Right? Okay, so use topical.
Better than nothing.
Better than nothing, exactly.
Fair enough. Yeah, well, my reason is simple as well. It's very easy to pop in a pill in the morning, move on with your day, and forget about it.
Compliance is way different.
Yeah, I remember when I was using topical minoxidil. It's a pain.
It's a drag.
Especially when you was using twice a day. Yeah, it's a hassle. Well, anyways, thanks so much for this interview, Dr. Ferreira. Pleasure.
You're welcome.
It was a great insight.
Great to have you. Thank you.